Hello, my name is Amy Wermeyer. I'm an associate professor and chair of the Pharmacy Practice Department at North Dakota State University. I'm proud to present the work of a team of colleagues of mine at NDSU surrounding the work of the OneRx project. The current work is entitled Integrating the Community Pharmacist in Upstream Prevention of Opioid Misuse and Accidental Overdose through Stigma Reduction. This work was also presented at the American Association for the Treatment of Opioid Dependence 2019 conference in Orlando, Florida. This project is focused on stigma, specifically stigma that pharmacists may carry toward individuals with opioid use disorder. For more background on work that preceded this project and examined factors related to pharmacist stigma at baseline, see our video abstract entitled Pharmacist Stigma Toward Patients Engaged in Opioid Misuse When Social Distance Does Not Mean Disease Prevention. It has been repeatedly noted in the medical literature that patients with substance use disorder fail to receive treatment because they perceive that healthcare professionals have stigma towards them, and they receive poorer quality of care when it is delivered by healthcare providers with a certain degree of stigma. Thus, it is important that we work as diligently as possible to reduce stigma toward patients with substance use disorders amongst healthcare professionals. The OneRx project features a training program that is designed to equip community pharmacists to partner with their patients and communities to reduce the burden of opioid misuse and overuse. The project features a training for pharmacists that educates them about implementation of upstream prevention of opioid use disorder via use of screening tools to assess risk of opioid use disorder and opioid overdose. And it includes specific modules that focus on stigma reduction and non-judgmental communication, as well as prescribing of naloxone. The OneRx training program is freely available at the project website, onerxproject.org. The objective of this work is to describe the impact on pharmacists' level of stigma toward patients or persons with opioid use disorder as a result of the training that they participated in through the OneRx project. The OneRx training featured 5 modules in total and was a total of 3 hours of training. Within that, 75 minutes were devoted to stigma reduction and partnering with patients. Aspects of the stigma reduction education delivered within the OneRx training were many and varied, and included things like physiologic effects of opioids on the brain, the vulnerability of the reward pathway within the brain to the effects of repeated use of opioids, and those accompanying involuntary neuroadaptations that occur with chronic opioid exposure. The training also discussed risk factors associated with the development of opioid use disorder, and focused a lot on self-awareness of the attendees toward their own stigma through exercises and word associations. We also discussed literature regarding stigma's effects on care provided by healthcare professionals who have stigma. We focused on changing the way we talk about opioid use disorder, mostly utilizing Table 1, with the words on the left-hand column with the red X indicating words that are stigmatizing and convey a certain amount of judgment toward individuals or situations involving opioid use disorder, and encouraging use of words in the right-hand column under the green smiley face, as these are less likely to convey stigmatizing approaches and viewpoints. We also focused on making analogies between opioid use disorder and other chronic diseases and their management over time. Finally, the stigma reduction portion of the OneRx training focused on use of open-ended questioning and reflective listening as a means to non-judgmental communication, and included video examples with role play and simulated patients demonstrating each of these concepts. In order to assess the effects of this training on stigma reduction, we utilized a pre-survey that was administered to the participants just prior to the start of the training, as well as a post-survey that was administered immediately following the completion of the training. And we followed up with a delayed post-survey that was administered 6 months after completion of the training. This was done in order to assess whether any changes in the degree of stigma that an individual may hold were sustained over time. This survey was based on the social distance scale. The social distance scale measures preference for separation from an individual with a mental illness or other characteristic, such as high-risk opioid-related behaviors. Social distance preference has been described as a central element and contributor to stigma for nearly a century. Unlike the recent social distancing measures widely practiced throughout the COVID-19 pandemic, in this context, social distance preference is in relation to groups or individuals and indicates attribution of undesirability, leading to separation and/or rejection. The social distance scale assesses a respondent's willingness to interact with a target person in different types of relationships, thereby reflecting their attitude toward the individual. When employing the social distance scale in this survey methodology, we utilize the scenario in the green box below to represent a target individual about which the pharmacist participants answered questions. The person in the scenario represents someone who may be misusing opioids, as indicated by early fills of oxycodone and obtaining prescriptions from multiple providers and filling them at multiple pharmacies. The social distance scale utilized asked pharmacists to answer questions on a 5-point Likert scale, indicating their willingness to interact with the person in the scenario in different situations. And the Likert scale went all the way from definitely unwilling to definitely willing to interact with this person in the ways asked in the social distance scale questions. Higher social distance scale scores represent a greater degree of preference for social distance and therefore a larger degree of stigma. We added the 6 social distance scale question scores to give an overall total social distance scale score, as has been done in previous literature. And we used non-parametric one-tailed t-tests to evaluate survey responses across time periods. So now we can take a look at the results of the social distance scale responses by the pharmacists who participated in the training. This column shows pre-training results and indicates that, on average, pharmacists were probably unwilling to interact with the scenario person by renting a room in their home, and probably unwilling to interact with the person in the way of that person marrying one's sibling. Pharmacists were neutral or ambivalent about interacting with the scenario person by having them be a next-door neighbor or introducing them to one's friends. But pharmacists were probably willing to counsel this individual if they were their patient, and were probably willing to discuss naloxone with this person. The overall average score at baseline was above the midpoint for the scale. The maximum score would have been 30, and that's an indication that, on average, pharmacists harbored a fair amount of stigma toward the individual in the scenario at baseline. When looking at the post-training mean, we can see that there was a statistically significant drop in the amount of stigma or the amount of social distance preference about renting a room to the person in the scenario, about introducing the person in the scenario to one's friends, about having the person in the scenario marry one's sibling, about counseling this individual, and about discussing naloxone with this person. And there was a statistically significant change in the overall social distance scale score, indicating a significant reduction in stigma immediately after the training concluded. As I mentioned previously, we also conducted this same survey 6 months after the training had concluded to see if the changes in stigma that were experienced as a result of the training were maintained over time. And this is really important because these have probably a greater bearing on how pharmacists will actually interact with their patients and individuals in their community over time and maintain the level of stigma reduction that they had immediately after the training. So we can see that when comparing the pre to delayed post, that's what this far right-hand column tells us, there was a statistically significant change in the pharmacist's willingness to consider renting a room to the person in the scenario in their home. This is statistically significant as it was a change from the pre training mean to the delayed post-training mean, meaning that there was a difference from the very first time point they answered this question to the 6 months later time point that they answered this question. And so therefore, the change in stigma was maintained over 6 months. The same is true for the feelings about introducing the person in the scenario to one's friends, as well as about discussing naloxone with the individual. And the overall social distance scale total score maintained a reduction over 6 months, indicating a very positive change in the amount of stigma that pharmacists held toward an individual with opioid use disorder. The implications of these findings are quite significant. We can see that the social distance scale total scores reflected a significantly lower preference for social distance after the training, and this stigma reduction was sustained over a 6-month period. The significant change in items 5 and 6, which related to interacting with the scenario patient in a clinical setting, suggest improved pharmacist-provided care related to their reduction in stigma. However, survey responses don't necessarily 100% translate into actual behavior, so this finding should be interpreted with some caution in terms of its predictive ability to determine how pharmacists will actually behave. Finally, other healthcare professionals have similar baseline preference for social distance toward patients with substance use disorders and mental illness in general, and therefore they may benefit from trainings like this one. In conclusion, we have shown through this work that delivery of a 75-minute training that focuses on stigma reduction is effective in lowering overall levels of stigma among pharmacists toward opioid use disorder. We've shown that emphasis on the disease model of addiction, drawing analogies to other chronic diseases, including their treatable nature, an emphasis on stigma self-awareness, and on language use that reduces stigmatization and judgment is associated with improvements in pharmacists' stigma and a reduction in their preference for social distance from persons who display opioid misuse characteristics. These are very encouraging findings and suggest that trainings such as these should be delivered more widely, including in health professions training curricula, perhaps. Thank you very much for your attention to this presentation, and I welcome you to reach out to myself or any of the OneRx team members you see listed on this slide. We would be happy to engage in further conversation with you around this work.